Standardizing Psychiatric Care, a model for diagnosis and treatment of major psychiatric disorders, video 1 of 4 general principles underlying most common psychiatric disorders. These videos are dedicated to my patients who taught me the art of clinical psychiatry, and to my wife Dolores, as well as to my children Simran, Deepti and Rebecca, and grandchildren Amaya, Elena and Dave for their love and support. This is me. I am a psychiatrist in private practice at the Carmel Psychiatric Associates, 7301 Carmel Executive Park Drive, Suite 200, Charlotte, North Carolina, 28226, USA. My qualifications are, namely, I was born in 1937, so I am about 75 years old, in India, which is now in Pakistan, raised in Delhi after partition. I went to Banaras Hindu University and finished my bachelor's and master's of pharmacy in 1958 and 1960. Then I went on a scholarship to Munich, Germany to do my PhD, and then later on at the age of 50 almost, I went to medical school to do PhD to MD program in Juarez, Mexico. Further, I did my internship and residency in psychiatry from 1987 to 1990 at the University of Nebraska and Creighton in Omaha, Nebraska, and the 4th year at the University of North Carolina at Chapel Hill in North Carolina. Further, I have been a professor and researcher at the Punjab University, Chandigarh, India, Max Planck Institute of Biochemistry, Munich, Germany, National Institutes of Health, Bethesda, Maryland, Wake Forest Medical School, Winston-Salem, North Carolina, University of Texas at El Paso, USA, and also published over 80 papers, which are right in my book, which is right, you can see that on my left side. Further, I have been a psychiatrist in private practice of adult psychiatry from 1991 to the present in Charlotte, North Carolina, and also I did the acute hospital care from 1991 to 1999, and currently I am doing my outpatient office practice of psychiatry for adults, and I have seen more than 7,000 new patients. Further, I published a book called Solving Psychiatric Puzzles in 2004 through the Author House. I have no financial support from any pharmaceutical industry or from any insurance company. These videos are produced and financed through my own personal resources. The objectives of these videos are, namely, to improve the quality of life of all people, to help patients and their loved ones understand the dimensions of mental illness, and to understand the clinical practice of psychiatry so as to have uniform standards of diagnosis and treatment by clinicians all over the world, thus reducing costs and ensuring consistency in patient care. In the overall summary statements of these videos are, namely, mental health disorders are global or of a global nature and is a big challenge. 15 to 20% of the population will experience mental illness in his or her lifetime. These illnesses are chronic and lifelong. Regardless of duration, they have huge impact on physical health as well as the functioning and relationships. There are no blood tests or head scans or paper pencil tests to diagnose mental illnesses accurately. All information is gathered in face-to-face interview with patients and their families. There are no standardization for these interviews and for subsequent diagnoses and treatments. Thus, many patients remain undertreated with residual symptoms of overtreatment with side effects from medication. Through my experience of treating more than 7,000 patients over 22 years, I describe a model for diagnosis and treatment in 4 videos. Namely, video 1 describes general principles underlying most common psychiatric disorders. Video 2 highlights psychiatric drugs and natural treatments. Number 3 offers a model for psychiatric evaluation and my recommendations for treatment. Video 4 features the voices and stories of my patients from my practice. Further, based upon my experience, we can successfully treat most common mental illnesses not only with psychotropic drugs and also but also refraining from alcohol, cigarettes and illegal drugs, and sustaining good sleep, a regular exercise regimen, and healthy diet, yoga, breathing, exercises, and meditation, and prayer. They are very, very useful. These simple procedures can reduce medical expenses and bring more joy to our life. The overview again for video 1 is general principles underlying most common psychiatric disorders. Number 2, psychiatric drugs and non-drug therapies. Number 3, psychiatric evaluation, pharmacological treatments, and follow-up care. And number 4, voices and stories of patients and the future of psychiatry, as well as the literature that I consulted for these videos. Video 1, general principles underlying most common psychiatric disorders. The standardization of psychiatry and psychiatric illnesses namely started in the United States in 1952 with DSM-1. DSM stands for Diagnostic and Statistical Manual of Mental Disorders, and the progression of these books have been namely DSM-2 in 1968, DSM-3 in 1980, DSM-3R, which was the revised one, in 1987, DSM-4 in 1994, and again a revise of the DSM-4 in 2000, and most recently DSM-5, which was published in 2013. Now, mental illness, what's the definition? Is a syndrome, means collection of symptoms characterized by disturbances in cognition. Cognition means thinking, focus, attention, coming to decisions, emotional regulations, or behavior that reflect a dysfunction in psychological, biological, or developmental processes underlying mental functioning. Further, mental disorders are associated with significant distress or disability in social, occupational, and or other important activities. The mental illness is very global, namely according to World Health Organization data from 2010, mental and behavioral disorders such as depression, anxiety, schizophrenia, and drug and alcohol abuse cause about 23% of total years lost due to this disability. Most disability occurs especially during the ages when we are very, very productive, namely 15 to 39, and this is a huge burden on the families as well as on the societies. There are top 10 causes of disability in the world, namely depression, tuberculosis, traffic accidents, alcohol use, self-inflicted injuries, manic depressive illnesses, war, violence, schizophrenia, iron deficiency, anemia. It is interesting to note that 4 of these disabilities are psychiatric illnesses, and further the hypothesis underlying these video series is or are: number 1, the brain mind is the source of healthy and unhealthy cognition, behavior, and emotions. Brain chemistry, hormones, body biochemistry, good physical health, diet, exercise, love, supportive relationships, geography, and resilience in facing life stressors affect our cognition, behavior, emotions, and functioning. Brain chemistry can be changed by pharmaceuticals, talk therapy, which is psychotherapy, food, exercise, spirituality, relations, and other positive or negative events. Psychiatric disorders have heterogeneous etiologies. That means there are different root causes and they are not all the same. Further, the future of psychiatry is becoming brighter as increasing number of major disorders are successfully treated with medications and therapy. Now, this is a bell curve. Bell curve describes a normal distribution. On this curve, we can put so many things, namely on the right side, we can have the most productive people, and the left-hand side is the least productive one, then rest of them are in the middle, or namely the tallest people on the right side, the shortest one on the left side, and in between are the wealthiest and the very poor. Now, similar principles apply in psychiatry as well, namely some people who have got depression, they will be most depressed, and we can distribution wise put them on the right side, then the least depressed, and then in between we all go through those features namely through any stressors, death of family members, death of our pets, or losses of job, etc. So, this curve is extremely critical in evaluating doctors, lawyers, accountants, as well as individuals' relationships. So, this bell curve is extremely important, and it has tremendous applications. Now, what are the psychiatric symptoms? Now, psychiatric symptoms, number one can put into a quantitative form, namely one can be very depressed or mildly depressed or moderately depressed based upon what the trauma has been, and these are so called quantitative one. And again, the trajectory, the cutoff line where we say, well, this becomes a mental illness. I gave you the example of depression, that could be anxiety, that could be panic attack, and where one cannot function. So, the functioning is the bottom line in school, home, work, and social settings, whereas the qualitative ones are those differences such as paranoia. Not everybody feels paranoia, whereas people have the depression, they have the anxiety, which is again in the quantitative range, and people also have hallucinations. Again, these are qualitative differences. Likewise, delusions, alcohol and drug intoxication, and the withdrawal symptoms, as well as panic attacks and the bulimia. Now, most common psychiatric disorders I have listed on this slide, namely adjustment disorder, alcohol and drug use disorder, Alzheimer, anxiety disorder, attention deficit hyperactivity disorder, bipolar disorders, bulimia, delusional disorder, depressive disorders, sexual disorders, impulse control, intermittent explosive disorders, obsessive compulsive, oppositional defiant, insomnia, schizoaffective disorder, schizophrenia, and personality disorders. Now, the personality disorders are the most complex ones. According to DSM-4, they were put into clusters such as eccentric disorders such as paranoid, schizoid, and schizotypal, and cluster B, dramatic, antisocial, histrionic, narcissistic, and cluster C, anxious, avoidant, dependent, and obsessive compulsive. The personality traits, this is a very interesting development, namely in 1995, Dr. Oldham and Morris proposed a model where the personality traits are described, and personality traits are namely consciousness, self-confident, dramatic, vigilant, mercurial, devoted, solitary, leisurely, sensitive, idiosyncratic, adventurous, self-sacrificing, aggressive, and serious. According to Dr. Oldham, when these traits go into the extreme, they become disorders, and they define as personality disorders. And these authors have done an excellent job in defining each of these traits. However, this book and the content have not been well used by neither psychiatrists nor by psychologists. The psychiatric disorders, as I briefly mentioned in previous slides, is namely all over our lifespan. Children have some specific disorders such as learning disability, ADD, ADHD, separation anxiety, oppositional defiant, depression, conduct disorder, whereas the adults also have anxiety, depression, psychotic disorders, alcohol and substance abuse, schizophrenia, bipolar. Females have particularly their own special categories such as premenstrual syndromes, pregnancy, postpartum depression, postpartum psychosis, and also the menopause. And geriatrics, of course, we have dementias. Again, we can have all the other adult illnesses, including delusions and chronic illnesses. Now, this is a new concept that I am bringing on this slide, namely relationship orbits. My view of seeing relationships is that we all are into orbits. Orbits means we spend time as an adult with our families, friends, and work. And I have mentioned here where the P means personal, J means job, culture, C means culture, S means social, and F is family. However, it's very important to see that as a child, when we are growing up, we spend most of the time with our mother or families. So our orbits are dealing more in that area. As an adult, as I mentioned on the screen, when we are really very old, then probably our orbits could be a part of our chronic mental illness and also some relationship losses. So this is a new concept, namely throughout our life we have these relationship orbits at work, home, social settings, church, as well as with our families. Now these relationship orbits can be mathematically defined in a way that if we define the so-called life energy as 100 units, that means all of us at a given time, a day or a week or a month or a year, have only certain amount, that is 100 units, then our relationship can be defined as R1 T1. That means the time that we spend in relationship 1, and also R2 T2, relationship spent in with the time in 2, etc. Now throughout our life these orbits change, and LE is a defining moment in the sense that if we have mental illness or mental disorders, they take away quite a substantial amount of our time and energies through the so-called life energy. And what we need to do is to convert the negative energies to the positive one. But this is a mathematical equation which is, I think, I am proposing, and you won't find anywhere in the literature. Now what are the factors that affect psychiatric disorders? Number one, medical issues. If somebody has cancer, heart problems, pulmonary problems, they definitely affect our brain chemistry and thus the brain disorders. Then again, drug use, alcohol, nicotine, caffeine equally affect all of our psychiatric conditions. Then how old we are, sex is a factor, education becomes also a factor, family history is very, very important, because we are all a product of the genes from our parents, father and mother, and if any one of them have any mental illness, it may or may not transmit, but that's a possibility that children may have it, or our own children may also get the same condition. For the geography means if I am living in the United States, my condition is different as compared to India or Germany. Should I go there and start living there? So that's going to affect my psychiatric condition as well as the treatment for that. And again, the environment, namely how bad we are we living in Iraq or in Egypt or in Afghanistan? These are major factors. Likewise, food, malnutrition, hunger, but obesity is becoming a huge problem in our society and the Western societies. Likewise, childhood abuse, physical, emotional or sexual, are equally very important in the course of a mental disorder. Stressors, sleep, war and peace, hobbies and travel, exercise including yoga, meditation or prayer are very, very important in the course of a illness, and likewise supporting relationships. Now how to measure these things? This is a very, very important question. In our routine day-to-day treatment, we have no way of measuring these things because things are very, very complex. However, at the research level, people have developed rating scales such as Beck Depression Scale, Hamilton Anxiety and Depression Scale, Yale-Brown Obsessive Compulsive Scale, and Scale for Assessment of Positive and Negative Symptoms in Schizophrenia, and Mini Mental Status Exam. Now, for the first time in the DSM-5, which just came out a few months ago, there is a measure, namely they are defining from a mental condition from 0, slight, mild to moderate and severe, and also they are going that one must exclude at least the 13 domains, namely depression, anger, mania, anxiety, somatic symptoms, etc. And also these scales have described in a severity form, but this is the first time that any of these DSM have done that. Further, they are also looking into the disability part, that how disabled one is, and these things again have not been very well defined. It's a proposal, and I must say in all my years of 22 years as a psychiatrist, I have always been measuring on a scale of 1 to 10, means 10 being no symptoms, 1 being the worst one. I ask each and every patient where they are, and likewise their functioning at a social level, personal level, family level, work level. So, but those measures are very, very important. Now, how to diagnose or how formally to put the diagnosis? Again, in DSM-4, there are 5 axes until that time, and axis 1 describes all the psychiatric disorders that we find in a patient. It could be just 1 or it could be 4, namely bipolar affective disorder, namely it could be alcohol abuse, it could be obsessive compulsiveness, it could have PMS features into it, it could have bulimia into it, and other features. And again, we have all those psychiatric disorders are in the so-called axis 1. Axis 2 is a personality disorders as well as mental retardation. Now, personality disorders are quite difficult to determine at the interview, and even because there are so many overlapping symptoms. But again, I think that there is a way to do it, and that is according to best is from the Dr. Oldham's book. The physical problems what a patient is going through is described in axis 3. Any kind of stressors, financial, relationship, job, physical, they are listed in axis 4, and then axis 5 is a global assessment of functioning, and again that functioning is very, very ill defined, and again what I have done in my practice is put on a scale of 1 to 10. Now, in DSM-5, for example, they have gone away these axes and made all the psychiatric conditions into 1 and replaced the axis 4 with the V code according to the international diagnostic system, and axis 5 is also being substituted with the disability assessment scale. Now, the summary of what all I have described so far is namely mental disorders and its global impact on disability in the world, DSM-1 to DSM-5, and the importance of the bell curve in psychiatry, and also what are the most common psychiatric disorders and personality disorders. And again, the new concept of relationship orbits and the life energy are proposed in this video, as well as the multi-axial diagnoses and the recent changes in DSM-5.